I'd like to introduce our next speaker, Kevin Franciotti. Kevin graduated from Northeastern University in 2013 with a degree in neuroscience. As an undergraduate, he completed an internship as a research assistant at Harvard Medical School, working on the Phase 2 dose-response study, investigating the therapeutic potential of MDMA-assisted psychotherapy for treatment of cancer-related anxiety. Kevin was also one of the founders of the Northeastern chapter of Students for Sensible Drug Policy, and in 2009, the group hosted and co-sponsored the Boston Ibogaine Forum. He now lives in New York City, where he is enrolled in a clinical psychology graduate program at the New School for Social Research and is pursuing a doctoral degree. Please welcome him. Thank you.
Good afternoon, everyone. We are getting down to the wire. What an amazing conference. I'm so honored to be presenting this talk, my first academic conference presentation ever. So thank you. Thank you very much. And I'm not sure if I'll be able to beat the venue. This rooftop situation is pretty great. Right now, as a humble first-year graduate student, the main part of my current research is exploring the early literature to get a better understanding of how the use of psychedelics for treatment of psychotic disorders emerged, why it didn't sustain as the other applications for psychedelics, such as in the treatments of neuroses, alcoholism, and existential anxiety associated with life-threatening diagnosis, and whether there's a realistic path to resume this once promising area of investigation. The use of psychedelics in the treatment of psychotic disorders was tied closely to the work behind the emergence of the psychotomimetic, aka model psychosis theory, about the similarity of psychedelic states with endogenous psychoses. Grinspoon and Bachelard noted in the book Psychedelic Drugs Reconsidered that as early as the 19th century, experiments with cannabis and mescaline revealed some phenomenological similarities with so-called psychotic states. In the psychiatric treatment of patients suffering from psychotic states, even the preliminary stages of treatment prove highly difficult because patients struggle to communicate with their doctors and therapists. One of the attempts to overcome this difficulty in 1929 was the use of sodium amytal, aka truth serum, which began to be used on patients in an attempt to help facilitate these diagnostic interviews. As you can see on the timeline, 10 to 15 years later, Albert Hofmann discovered LSD. Although psychedelics like mescaline had already been discovered, LSD marked a true turning point because of its low toxicity and extremely potent effects in very small doses. As early attempts to determine the effects of LSD and potential medical applications were underway, Werner Stoll, the son of Sandoz president Arthur Stoll, and a colleague of Dr. Hofmann, presented the first study on LSD's mental effects in the Swiss Archives of Neurology. Stoll included 36 patients with schizophrenia from the psychiatric clinic of the University of Zurich and reported that LSD was found to blunt the usual suspiciousness of schizophrenic patients in interacting with the staff. So even in the very first workings on LSD in humans was applied to psychotic patients. A few years later, the first American article about LSD appeared in Diseases of the Nervous System. Although Stoll had previously suggested LSD's therapeutic potential in his first report, this paper, however, titled LSD as an Aid to Psychotherapy, clearly took that a step further. Anthony Bush and Warren Johnson, psychiatrists at St. Louis Hospital and Washington University Medical School, studied how LSD affected information gathering from patient interviews similar to the sodium amytal technique. 21 patients, most who were diagnosed with schizophrenia, which included subtypes like catatonia, paranoid, disorganized subtypes, exhibited mild excitedness under LSD, and most notably, a desire to express some form of interpersonal connection with the staff while under the influence. From that initial investigation, 8 patients who had also been in talk therapy were selected for another LSD trial, 3 with catatonic subtype, and the other 5 out of the 8 were non-psychotic patients. But all the patients became more open during their LSD sessions, offering more insights than usual to their internal states. The authors concluded that LSD may offer a means for more readily gaining access to the chronically withdrawn patients. Another early LSD and psilocybin researcher, Duncan Blewett, who worked with the Saskatchewan group alongside Humphrey Osmond, Abram Hoffer, and others, and were predominantly proponents of the model psychosis theory, their main focus would become psychedelic therapy in the treatment of alcoholism. But in Blewett's Handbook for the Therapeutic Use of LSD, a procedure was outlined for psychedelic-assisted therapy and would also be used for treatment of psychotic disorders. So I'm now going to highlight one case from the work of Gary Fisher, a psychologist who followed Blewett's protocol. Last month, I traveled to Purdue University to access the Psychoactive Substances Research Collection in the archives of the Carnes Library, which houses a trove of uncirculated material from, among others, the psychologist Gary Fisher. Gary was one of the earliest proponents of LSD for use as a possible treatment for psychotic disorders. He worked with highly dysfunctional, treatment-resistant children hospitalized in a state-funded hospital in Southern California. He conducted informal research from 1962 to 1963 in 12 severely ill children between 4 and 12 years old, using high doses of LSD and psilocybin. His working hypothesis was that a psychosis is a massive defensive system of repression, avoidance, denial in the service of protecting the individual from experiencing early childhood trauma. Psychedelic drugs could break through this massive repression, wherein the child would re-experience these traumatic events and release the pain bound to those experiences. The first patient he treated was Nancy, an 11-year-old girl diagnosed with schizophrenia who had to be kept in continuous restraints due to self-destructive tendencies. She refused to eat and was considered to be near death. When discussions took place over initiating the LSD study, Gary and his colleagues decided to start with Nancy because she was in such bad shape that they figured at the very least LSD won't make her worse than she already is. If you can play the clip. This is from Nancy's first LSD session.
It sounded like an animal in distress. That's the best way that I could describe that. It was this howling and just terrible distress. And then it got louder and louder and louder. And here is this little piece of protoplasm making all this noise. And it went on and on and on and got louder and louder.
I imagine you are all getting kind of concerned then.
Well, it was a change, something different was happening. So that was encouraging.
Oh, okay.
And so it went on and just howling. And so finally, after about 4 hours, I don't know how she had the energy to do that, but after about 4 hours, and we would try to talk to her, during this, ask her what was she howling about and what was wrong and so forth. Nothing, no response whatsoever, just as though we didn't exist. But she never responded to anybody anyway. She never talked to anybody anyway. But then we kept doing that, and so finally we just gave that up after about 3 hours and just sat and looked at each other. And so finally, in my desperation, I just yelled at her. I said, "Nancy, for God's sake, stop this racket. I can't stand it anymore. You're driving me crazy." I expected an answer, And she stopped. And she said, and this is her first communication that we'd ever heard from her, "Leave me alone. I have a long way to go." And then she went right back to screaming and howling. And we just went, holy shit. There's somebody in there. There's a person, there's a live person in there.
Right, yeah. That was Gary actually talking on a podcast in the early 2000s. I encourage people to check out the rest of that interview if you're interested. In subsequent sessions, Nancy would open up about severe abuse she experienced, and after 11 sessions, the report Gary authored indicates that she hadn't been in restraints for several months and goes about the ward and yard and is seldom self-destructive. She eats well and takes care of her hygiene. She can carry on a conversation when she wants to. She has been recently making home visits and now attends hospital school in the mornings. Of the other patients, there were several other improved cases following these LSD sessions. Behavior became less erratic and more about fostering a feeling of connection with the treatment staff. A few began attending either the hospital school or some even attending outside the hospital. In the interest of time, I'm only going to use Nancy's example. Gary wrote a great summary of his research in an issue of the MAPS Bulletin, and there are several literature reviews I encourage those interested to look into. Conclusions from this area of psychedelic treatment are mixed for several reasons. Diagnosis of childhood schizophrenia versus autism, as though they are distinctly different diagnoses. At the time, they were often treated together in institutionalized settings, though there are case series and other reports with adults having primary diagnosis of schizophrenia. Also, there were no comparator groups, placebo controls, or double-blind, and outcomes are different in the way of how successful treatment is defined. Treatment of institutionalized patients often meant that their behavior around the ward would improve, or they'd gain a better rapport with their treatment staff. Many of these patients had such severe treatment-resistant conditions that the informal research conducted was mostly to see how the toughest cases would respond to LSD and psilocybin. Conducting this kind of treatment was controversial, not well-funded, and highly vulnerable to ethics guidelines being adopted more and more. And of course, just a few years later, LSD and psychedelics would be banned, and most research came to a halt. But a new drug would emerge in the 1970s with its own therapeutic potential. MDMA and its proponents, among the psychologists working with it, kept a low profile over fears of its prohibition. Regardless, it was banned in 1985, but here we are today, over 30 years later, on the cusp of prescription status for PTSD. Not meaning to be misleading about the title of this presentation, as we know that MDMA is considered an entactogen, meaning it allows people to experience an emotional openness and trust and bonding with others, while not considered a classical psychedelic like LSD or psilocybin. However, there are several reasons why MDMA is not only a good starting point, but may also have higher therapeutic potential for treatment of people suffering from psychoses. This is a book by Julie Holland, one of my mentors, who wrote a chapter in the Ecstasy Guide, which she also edited, titled Using MDMA in the Treatment of Schizophrenia. Though the book is now over 15 years old and there's newer research to add, in the chapter, Dr. Holland proposes some mechanisms of action for MDMA based on its pharmacological activity on serotonin and dopamine, both of which are known to be involved in the functional impairments of people with disorders like schizophrenia. Though there are effective medications today to treat the so-called positive symptoms of schizophrenia, such as paranoia, delusions, and hallucinations, many people still suffer from the negative symptoms, which include things like low motivation, social isolation, and hedonia, which is an inability to experience pleasure. These treatments arose out of the dopamine theory of schizophrenia, which believes that overactive dopaminergic release is the main contributor to the most severe symptoms of this disorder. More recently, theories around the role of glutamate likely explains more of the negative symptoms. But amphetamines in general exacerbate many of the positive symptoms of schizophrenia. So I do want to caution that while it may be helpful for some patients, it may have the opposite effect in others. However, many of these negative symptoms are in complete contrast with the effects of MDMA: enhanced sociability, enthusiasm, euphoria, an increased desire to speak with and connect to others, and a sense of openness and trust. One of the potential applications Julie believes MDMA could be used for is to intervene during acute first break episodes, as delusional paranoid states contribute to distrust of the people attempting to help treat them, and MDMA may attenuate that. While Julie doesn't work with treating her patients with MDMA, over the years she has received many unsolicited emails from people reporting their experiences to her. This first quote comes from a man named John, who was diagnosed with schizophrenia in his late teens, treated with clozapine and later olanzapine, was hospitalized with paranoid ideations, disorganized speech and thoughts with no alcohol history. You can see from that quote the actual positive symptom halted by his experience. There's potential therapeutic breakthrough in a state like that. The second quote, writing, is from James, who has a history of persistent auditory hallucinations, paranoia, referential ideation, complex delusions, a suicide attempt, and one psychiatric hospitalization. The third quote is from another patient who emailed Julie to tell her about his experience with MDMA when he decided to stop his antipsychotics for a short time, which I would not recommend. But the last quote is from a man who spoke to Julie several times over the phone, but since he couldn't send her anything in writing, he was so disorganized and grossly psychotic. Every time they spoke, he could really not, had trouble finding the words to describe how meaningful this experience was to him. But as you can see, that last sentence, and I think doctors should research on why that happened, kind of brings me to where I am today, even though I'm not a doctor. So given that all of the current human research using psychedelics aggressively screens out participants with any personal or family history of psychoses, we are likely a long way away from clinical trials using MDMA in people with psychotic disorders. And despite the first half of this presentation focusing on LSD and classical psychedelics, perhaps this highly controversial proposal is slightly less challenging to pursue using MDMA instead. Also, my hope for this research is not necessarily to propose MDMA or psychedelics as treatments for the primary psychiatric diagnoses. Instead, similar to investigations using MDMA in the treatment of secondary diagnoses, such as existential anxiety and psychological distress associated with a life-threatening illness, and social anxiety in high-functioning adults with autism spectrum disorders. Alicia Danforth, who is the co-investigator on the recently completed Phase 2 pilot study using MDMA in autistic adults, is another mentor of mine. Her mixed methods design for her doctoral dissertation on MDMA experiences of autistic adults is a model I am looking to use to investigate MDMA experiences in adults with psychotic spectrum disorders. She combined an online survey and clinical interviews to develop a case series of people reporting the effects of MDMA on their symptoms. I don't have data of my own to present. This is mostly my kind of theoretical basis and my early interest in my academic pursuit. So I'm deep in the weeds of the literature right now, kind of investigating all that I can among the work in the 50s and 60s. But I do have some ideas of where to start looking, and right now I am beginning to do that in a couple of roles that I have in New York City. I volunteer at Manhattan Psychiatric Center in the inpatient hospitalization ward for a psychopharmacology research unit, and I'm soon going to be recruiting on one of their clinical trials for antipsychotics, so it's going to have me traveling around New York City trying to meet patients all around the area in group homes, homeless shelters, on the street, to recruit for their clinical trial. But I hope that it might enable me to develop a rapport with individuals that could eventually speak with me about some of their personal experiences, whether they have a positive effect on their life or a negative effect on their life. I'm mostly interested in the ethnography of this, and if it is something that patients that are suffering are currently doing, I'm interested in exploring their experience about it. It's interesting, being out on the West Coast, I've been speaking with some friends of mine who work with these patient populations, either in community health settings or in emergency rooms. And in contrast to New York, where I have a lot of discouragement from the people that I talk to, thinking that they don't really know any patients with psychotic disorders that are using hallucinogens, as they call it. Out here, it seems to be a different scenario, and I've already talked anecdotally with folks that are sharing their experiences of their patients with me. So I'm currently looking at online forums where these discussions take place among patients as a way of gathering mutual support from one another. It's a bit of a complicated scenario, with moderators being very careful about what types of illegal discussions of illegal activity are taking place. And as a person without a psychotic diagnosis, I don't want to come in as a graduate student, asking all these questions for people that are, looking for support from the community. But I have already kind of taken advantage of some of the voyeuristic aspects of this, that I've been invited or added to the group after I've submitted a request, and I can say that these discussions are happening. So I would like to hopefully capture a lot of that, as well as combine it with an online survey that I hope to launch by the end of the summer, and working with other people to explore clinical interviews themselves. So with that, I left plenty of time for Q&A. I hope I could answer to the best of my ability the many questions that people likely have. And I will leave with a quote that, as I was out with lunch discussing the topic of my talk with a psychiatrist from Canada, reminded me of the Joseph Campbell quote when he was asked about the difference between a mystic and a psychotic person. Joseph Campbell answered, "Mystics are swimming in the same water that the psychotics are drowning in." So I hope to return to the next Psychedelic Science Conference with results from the scope of my modest graduate research. And thank you to all. These are my acknowledgements. If my clicker will advance the slide, maybe I can. So I owe a lot of gratitude to many people, both at the New School and in this community, who have advised me, mentored me, and given me some directions of where to go. But can't seem to get those names up. So thank you.
Hi. When I was younger, I had an acute fascination with the character Syd Barrett. And I think, so Syd Barrett, if you're not familiar, he was the founder of Pink Floyd and heralded as a creative genius in his youth. But he developed mental illness, schizophrenia, and is credited. People typically attribute the development of his mental illness to an overuse of psychedelics. People say that he went crazy because he took too much LSD. And I'd like to hear your perspective on that, if there actually is any validated scientific findings about if using psychedelics can actually make somebody psychotic or give rise to the development of schizophrenia and other mental illnesses.
Yeah, as I mentioned earlier, with good reason, all of the active clinical trials around the world aggressively, like I said, screen out any potential subject with a personal or even most times, family history of psychotic disorders, suicide attempts, things like that. And from a research standpoint, when you're, recruiting a sample, those types of subjects could potentially experience more exacerbated phenomena while they're under the influence. Now, you mentioned Syd Barrett. I'm not a clinician, but obviously, we often hear stories about people that were experimenting with psychedelics, and it either precipitated or exacerbated or was the root cause of their diagnosis, their eventual diagnosis. So I certainly am not going to say that it's either a cause or a potential cure. There are what I'm working in is this 2-decade period of time where LSD was a new drug, it was being tested around the world, and with institutionalized patients that were already actively receiving care were receiving these substances. So it's in a completely different context. When you're talking about non-medical use, you have impurities, you have different dosing problems. So for many people, it does trigger an early episode psychotic that turns into potential diagnosis. So I'm kind of just laying the groundwork to explore what else is out there, and if I can make an assessment of what the potential risks and or benefits are.
Yeah, thank you for doing this survey. I was wondering if you saw anything in the research about non-tryptamine acting hallucinogens like salvia, or even some of the other very powerful tryptamines like DMT. Thank you.
Yeah, like I said, I haven't actually conducted the survey yet, so I will humbly return when I have data to present on that. But as far as your question, I would say that there's some anecdotal case reports in the literature about other non-classical hallucinogens. I've spoke to actually some providers at ayahuasca clinics in South America that have actively treated patients with psychotic disorders, and I'm sure those have had some highly negative outcomes, and there's been some that have probably had positive outcomes. So I'm sorry that I can't answer that more fully.
So, because the brain is still developing until we reach maturity at about age 25, some people say it's better not to smoke weed or do any drugs until after 25. I saw that the average was about 9 years old. I have a little baby mouse, or baby snake. He's 5 months old. They reach maturity at 5 years. And I was wondering, would it be bad to smoke weed with my snake or to give it acid? Would it negatively affect its life? I buy a little mouse to feed it once a week. It costs $1. I gave it some weed and it opened its eyes, and I haven't given any acid yet. So,
Okay.
I mean, what do you think about what is the right age? Would you say?
What is the right age
What is
for a
harmful?
snake or?
Any sort of living being. There's maturity, and then a lot of people will say it's best not to take drugs until after our brains have fully developed. But I saw that LSD and ayahuasca are administered to children whose brains are still developing, and it's seen as a positive effect instead of negative.
No, I didn't say LSD and ayahuasca are administered to children. I said Gary Fisher, one of the early investigators who was working with institutionalized children, highly emotionally disturbed, self-destructive, around the time when LSD was this new discovered drug. It was sent around by Sandoz to different people working in the field, psychologists and researchers, and one of the applications happened to be treatment of children. Nowadays, you'll be hard-pressed to find an IRB that's going to approve that protocol. I'm sorry?
Here, you take this. Just hang on to it. There are other people who have questions that they'd like to ask. Could we let somebody else have a chance?
Well, what I wanted to ask you was, are you familiar with the work of the Hearing Voices Network?
Yeah, I didn't want to necessarily mention any organization or forum specifically, but that is one of the peer support groups that I am kind of keeping watch of to investigate those people. Yeah.
Hi, real quick, your psychedelics, like what, all of them, LSD, DMT, all, I mean, when you say psychedelics, you mean all, do you have preferences? Do you work with some better than others?
Yeah, I don't work with them.
But I have to follow.
Yeah, I'm looking in the literature, which I
Okay,
would
okay,
say,
sure.
Yeah.
So
Any psychedelic.
Okay,
that
so
was used in
the
literature.
profile of where it hits the brain, how that combines with the profile of the psychotic person, like the parts of the brain that are of interest, the voxels that are of interest in the brain for the psychotic person, and how does that overlap with the various different kinds of psychedelics? I think that would be a very important coefficient to look at. What do you think? What do you think of that?
I agree. The lab of Robin Carhart Harris at Imperial College has shown in some of his brain scans with healthy volunteers that the brain actually looks like an individual in the pre-psychotic state, an early aspect of that emergence. So, yeah.
Hello. Just a little kind of concern, and I want to see what you think about it. So basically, it could be the case that on psychotic people with psychotic symptoms, if you give them, let's say, LSD, we know that LSD intensifies the amount of consciousness that you have. Maybe on high doses, you might even get like 100 times more consciousness. And if we judge the therapeutic outcomes of it just based on how they feel afterwards, but do not take into account maybe all of the bad experiences they endured on the LSD state that they can't remember and have no access to. I wonder whether maybe from a utilitarian point of view, you're creating way more suffering than you are preventing.
Okay, odd place for a round of applause. Well, you know, I'm coming at this from, you know, an angle of a researcher looking at the early literature. I certainly agree and acknowledge your point, and I'm not here to make any claims one way or the other. I'm curious from an epidemiological standpoint the types of things people are doing and whether I can hear from the patients themselves if it's benefited or harmed them. To answer the question about whether Gary's research specifically harmed the children he was treating, I would highly doubt that he would continue his work if it was found to be done. Patients with catatonia, subtype schizophrenia, who are just non-responsive, non-communicative, been sitting in hospitals for years. The administration of LSD was found to lead them to a more kind of, he called it an excited state, but it kind of opened them up and led to some communication. There were some that were non-reactive, and there were some that reacted negatively, and at that point, they no longer used the drug. But, you know, again, from an ethics standpoint, that's part of the reason why it would be unethical, likely, to approve of a research protocol giving this, because, you know, the first impetus is to do no harm.
Yes, if you look at Stan Grof's work, he says very clearly that in the 1950s, when East German psychiatrists and Eastern European psychiatrists were all using psychedelics to mimic psychosis so that they could understand their patients better, it was very well known that anyone who had taken LSD, including the psychiatrists, should always be supervised for 24 hours because there was a great risk of sudden suicide that occurred rarely but regularly. And I wonder why you haven't mentioned that, and I haven't heard anybody at this conference or at any other conference mention those scientific findings.
Okay. Rarely but regularly. Okay. Yeah. In medical settings, psychedelics should be administered in a supervised way, and people should be monitored after. I don't have any disagreement with that.
I have to really hand it to this speaker. He has fielded some of the most really difficult and complex questions that have been asked here. And well done.